Scott Nickerson, Bighorn, Wyoming. For Dr. Petrova, in the surface profile studies you've done, do you know whether the diabetic control are neuropathic or non-neuropathic?
So the patients that we studied in the diabetic group, they were matched for age and duration of diabetes with the Charcot patients, and they have less neuropathy compared to the Charcot patients as expected.
But we don't know whether neuropathy is absent or present in those controls?
It was great. It was present in both groups, but it was greater in the Charcot patients. And I would agree that that is one of the very important confounding factors. But when you plan such studies, it's so difficult to control for everything, isn't it?
Thank you.
In line of that, maybe, while we're waiting for the next question, is in that study, you compared Charcot patients with neuropathic diabetic patients and controls, where the patient with Charcot, to speak with the first, to use the terminology of the first speaker, had they had active Charcot, or was it Charcot, a history of Charcot?
All patients were with active Charcot, and all patients were recruited to the study at the time when they presented to the clinic, and they have not had previously casting therapy, so this was their initial presentation. They were as active as one can imagine.
Sorry, I didn't quite hear you. How long did they have active? I missed, sorry.
They had active Charcot osteoarthropathy, and they were recruited to the study at their initial presentation, and none of them had had previous casting therapy.
Okay.
So this was almost within a week from their initial presentation.
Okay. Because did you ever compare a patient with a history of Charcot and then do the comparisons?
No, we didn't go that further. One of my collaborators, Guillaume Malibo, was supposed to actually study the osteoclastic culture changes in patients throughout the progression of the disease, and he showed the reduction in that activity, but that paper's not been published. And this was not the purpose of this research.
So if you have, for instance, somebody who has a fracture, and then you look at osteoclast activity, so could it be an epiphenomenon instead of a causal?
Of course it can be, and I don't think we've not had patients who have presented with fracture, so we've not carried out these experiments in people who had a pure fracture.
William?
I think they're really clever questions, because I wanted to ask the same one, so they must be very clever. But the question is whether the abnormality, the difference between Charcot people and non-Charcot people, is only there at time when the disease is active. In other words, whether the described difference could be the consequence of the disease rather than the cause of the disease.
I think there is. I think the field is really open for quite a lot of further work, and what we're really trying to report here is a completely new approach to this condition. And I think, and I do believe, this is the right way to look forward to many more new data coming.
A question, yes.
So thank you so much, both of you, because so many new thoughts appeared. So
First, state your name, please.
So my name is Irina Guryeva. I'm a diabetologist from Russia. So thank you, absolutely outstanding both talks. And so my thoughts is it so much inflammation and genetic predisposition involved in this disease matching? Is it possible to stop this process after avoiding mechanical stress, or should we await the new bone destruction in any patients? If yes, how can we explain that only one lateral, one side Charcot formed in half of the patients, and in the other half of the patients the bilateral Charcot involved? So do you think that is much more pronounced, not many other risk factors, not only genetics play the major role?
You go.
You go.
I'm afraid I couldn't understand the gist of what you're
Why?
saying.
Of course. Is this persistently inflammation should we await? What should be triggering? The mechanical stress or overload of the bones in one patient, for example, who, one Charcot for one side occur and stop forever. But for other patients, we have huge deteriorated both sides destruction, for example, with loss of stability in both ankles, for example, and I have such patients, we lose both legs after great disruption of Charcot. So that's why I'm questioning, should we await the new formation of disruption for all the patients? Should we follow the predisposition of genetic for the one patient and not for the others? What should we await for the future of different kind of patients? Maybe, sorry, my thoughts is a little bit too much that I'd like to express.
I'm afraid I still can't. Your voice is being distorted by the microphone, I think. Nina, can you answer?
Irina, you talked about, could you help us please? You talked about the acute inflammatory phase. And you also mentioned the bone destruction.
Yes,
And what we usually think, if we go back to what William said, we usually discern the active phase and we discern the inactive phase with a huge deformed foot.
Right. One, we can, if the inflammation could be raised in different situation, progression of the disease. One, we have only one episode of Charcot in the patient and it stopped forever and never the other foot involved. So my thoughts is...
you mean that some patients have a one lifetime episode, while other people have recurrent Charcot.
And forget forever, and the other patients has had new episodes and may even lost both legs.
Is there an explanation why some people have recurrent, or like you said, have Charcot on one foot and then later on have Charcot on the other foot?
Sorry to be obtuse before, but I understand. If we knew the answer, I think we would know an awful lot more about Charcot, because just thinking it's a disease of people with diabetes, of peripheral neuropathy, and it's symmetrical. So why do we only get bilateral disease in 20% or 25%? Why do people get the disease and then never get it again, even though they've still got diabetes, they've still got neuropathy? In the absence of any clue as to a more subtle reason, the only thing I could suggest is a change in the capacity to mount an inflammatory response, that with the passage of time, the nervous control of their blood flow or their peripheral arterial disease changes. Have you got any ideas?
I don't think clear ideas, but might be, it depends on the degree of inflammatory disruptions personally. It's my first possible explanation, and the second might be it's some biochemical points of view, because some patients may overload one leg persistently and maybe less the other leg. So I maybe from biochemical explanation might be exists. Maybe osteoporosis like risk factors. For the others, I don't know clearly the answer.
I prefer your answer. I think it's a more subtle explanation. I don't like mine.
Well, yes.
Can I just add a little bit more about this? I think you open a very interesting subject. It's really about how early we see these people in the so-called active phase. I can definitely say that we actually at King see patients much earlier, and we try to diagnose them in the earliest active phase. So it really depends on how do we diagnose it, and if we really use, for example, an abnormal X-ray as your starting point to diagnose Charcot osteoarthropathy, we are really late. And recently, Professor Chantelau from Germany proposed and modified the Eichenholz classification, adding the so-called MRI stage, when we can definitely see evidence of bone inflammation as noted by bone marrow edema, and also other imaging techniques that we use, for example, as bone scans also show early bone damage and inflammation. And also Professor Carper, in a series of patients, they used PET-CT technique and really noted that you may have minimal or almost no bone damage detected on an X-ray, but you have other imaging techniques which will detect the abnormality. And therefore, we believe that trauma is really important trigger in this condition, and therefore that's why the presentation is unilateral. Yes, we've seen many people who have, I will call them recurrent Charcot episodes on the same foot, but some of them would develop also bilateral deformity, and this may be again triggered by a new trauma.
Well, maybe David has something on that, because he also studied foot pressure measurements on the contralateral foot in patients with Charcot. David.
My gosh, well, thank you for putting words into my mouth, and then I'll put my foot in the same mouth. But before I get to that, that's less important, through the chair. What is fascinating is that what you're both elucidating are possible targets for therapy. And I may have missed it, but can you both talk about potential therapeutic targets? Should we be hitting these people with potent anti-inflammatories, like you've already mentioned, like a TNF-alpha, or is that a stupid idea? Or a rank ligand inhibitor? Dr. Jeffcoat, Dr. Petrova.
I'll give the simple answer and I'll ask Nina to give the complicated one. I think it's surprising that we haven't actually looked at the use of anti-inflammatory agents which we have available to us at the moment. Non-steroidals is obviously difficult in people who might have nephropathy, but why we haven't used glucocorticoids, I do not know. I think it is something which definitely does need assessing, as it has been used, say, in rheumatoid arthritis. But as for specific therapeutic targets, I'm going to ask Nina to answer that one.
I always go the difficult questions. I think both ideas of RANKL inhibition and also TNF-alpha inhibition are possible, although I am not aware of any patients treated with neither of these drugs. What is really difficult is that we have a very window of opportunity to introduce these new therapies. So, and to do a clinical trial would be very difficult to try and recruit people who would be at the same stage of the disease, and they may work for some people, but they may not work for all of them. And therefore, the simple answer is I don't know. I'm a little bit now intrigued about this possible involvement of cathepsin K upregulation in the Charcot patients, because now there are trials which are at phase 3 study using cathepsin K inhibitors. However, we have completely no knowledge whether that may be the case. But if we hypothesize that both RANKL and TNF-alpha, which may be clearly indicated upregulated in this condition, are driving cathepsin K upregulation, this may be another potential target to look at. And this may be the future.
Nina, would you agree that, because I think David raised a very important question, that these mediators you've just discussed of bone resorption and activators of bone resorption also play a crucial role in bone healing? After a fracture, callus has to be removed, and that's one of the reasons we have this system. So if you would block this system, you might interfere with the fracture healing, because Charcot at the end of the day is frequently a fracture problem. So I think there's a great theoretical risk in introducing these agents What do you think? What would your comment be on that?
Well, there is some recent evidence actually, which is saying that TNF-alpha is also involved in bone formation, so it blocks bone formation, and this may be the case in our Charcot patients, and for this we really don't know. But I would definitely agree that bone formation is impaired in this group of patients, so we have this imbalance between the massive bone destruction and we lack an adequate bone formation. And our thoughts were in that direction, and that's why we conducted at King's a clinical trial trying to use PTH to stimulate bone formation in this group of patients, and we are actually analyzing this at the moment, so I don't have any further evidence to say whether triggering bone formation may be the clue. But we still need to learn a lot. We still lack a lot of knowledge in the pathogenesis of this condition.
Yes, please.
I'm curious, there's in the non-Western part of the world, the bone resorption that one sees in leprosy neuritis of Hansen's disease is so impressive, and it continues even after bacterial cure. And I'm wondering, does any of this work relate to leprosy neuritis as well?
We presume so, but I am not aware of any relevant work that's been done on it.
That was a very good question. Thank you.
Indeed.
Yes, please.
Yeah, my name is Peter Alton. I'm the clinical director at Circle Bodarchi over in the UK and founder of a new campaign and education initiative for patients called Undefeated. So I'm taking this thing down to a different level, if you like, and talking about triggers. Are you aware of any literature that I'm not aware of regarding the potential maybe of foot types or even something like a leg length difference being something which could contribute to triggering, as to why some people are more predisposed to this and others aren't?
I don't think we're aware of any data. I'm not aware of any. In this whole question about education and prevention, it's a very complex one. You would think we should be educating the professionals to detect the disease at the earliest opportunity, but it is so rare that actually it's not a practical option, except subliminally perhaps. And the best chance you've got of preventing it is someone who's had Charcot on one side and trying to prevent it on the other side, because they're the highest risk group. But nobody has systematically examined ways in which you can actually achieve that. And all you can do is just say, as soon as you get inflammation, come quickly.
So it's not more common in somebody who would have, for example, a high arch foot or a flat foot. It's not more. It wouldn't be more common in somebody.
Not that I know of.
I think our knowledge is a little bit limited because we don't have actually we don't have a model of the Charcot foot, and all we have is our patients, and all our experience comes from observations of patients. Therefore, a lot of research is still needed in this area.
Thank you.
Could I just make one comment in response to David's earlier question, unless there's somebody else waiting to ask? And this is the concept of giving agents, specific agents against the cytokine signaling pathway. The worry, I think, is Charcot differs completely from osteoporosis, say, because osteoporosis is a systemic distributed disease throughout the whole body, whereas Charcot just affects one part of the body. And I would worry about introducing an agent that might paralyze the normal function of TNF-alpha, which after all is doing a lot of other things apart from just regulating osteoclasts in one foot. So it would be something that would just make me cautious about doing the studies.
Okay. Well, thank you very much. I think we had a fascinating session. It shows that still a lot of research has been done, but if you compare that where we were 10 years ago, I think we made some major strides forward in trying to understand what is going on with Charcot. So maybe in the next 4 or 5 years we will have an answer on treatment. Thank you very much.